So this is the first installment of antiviral agents, and we're going to be targeting DNA viruses. Our objectives then are first to identify virus-specific targets that are approved by the FDA, classify drugs by molecular structure. For each virus, list the drugs that are commonly used for treatment, describe the metabolism of each drug, identify significant drug interactions within antiviral drug classes, describe major toxicities of each class, and describe the mechanism of drug resistance for each drug and each virus. So considerations for DNA viruses, antiviral agents. These viruses are intracellular organisms, so we need virus-specific drug targets, and these need to have low cellular toxicity and minimal side effects relative to the disease that we are treating. And this is a mini review of nucleic acid synthesis because we will be using it for our nucleoside and nucleotide analogs. So we have the four bases, adenine and guanine purines, cytosine, thymine, pyrimidines, and these are linked to deoxyribose. These two together then become a nucleoside. As soon as we add a phosphate to it, it becomes a nucleotide. So nucleosides are not active. Actually, monophosphates are not active. We need to add a total of 3 phosphates in order to get a nucleoside triphosphate, which will be recognized by the DNA polymerase. And this will be incorporated into the DNA. When it's incorporated, then 2 of the phosphates are given off as pyrophosphate. And we'll be dealing with all of these as analogs in antiviral agents. So if we have a normal nucleoside, it has a base and a deoxyribose, but no phosphate. A nucleoside analog then has a base, but it has an acyclic sugar, and we'll see the structure of that. And again, no phosphate. A normal nucleotide has base plus deoxyribose plus at least 1 phosphate. But we know that we will need a triphosphate in order to incorporate it into the DNA. A nucleotide analog then has a base plus an acyclic sugar plus 1 phosphate. Then pyrophosphate normally has no base, no sugar, and it's a diphosphate. Pyrophosphate analog that we're going to talk about has no base, no sugar, and actually is phosphonoformic acid, which only has 1 phosphate, and we'll take a look at that. So this is a list of the antiviral agents that we use for DNA viruses. We have nucleoside analogs, acyclovir and its valine ester, pencyclovir and its prodrug famciclovir, ganciclovir and its valine ester, and trifluridine. And then we have a nucleotide analog, cidofovir, a pyrophosphate analog, foscarnet, and an immune activator, imiquimod. So the diseases that we use these viruses for then, herpes simplex and varicella zoster, we use acyclovir or valacyclovir or famciclovir. If we have an acyclovir resistant strain of herpes simplex or varicella zoster, we can use cidofovir or foscarnet. For cytomegalovirus, the drug of choice is ganciclovir or valganciclovir, the valine ester. If we have a ganciclovir resistant strain, then we can use cidofovir and foscarnet. And finally, for human papillomavirus, we have imiquimod and trichloroacetic acid. So as far as the structure of acyclovir and valacyclovir goes, this is our normal nucleoside. It has guanine and deoxyribose. So acyclovir has guanine, but it has this acyclic sugar attachment to it. And then valacyclovir has that same structure. It has guanine plus an acyclic sugar, and then we link valine to it. And this allows it to take advantage of a valine transport that's in the intestines, so it can be used as an oral drug. So guanine is the normal base attached to an acyclic sugar. And remember, we're going to have to triphosphorylate it for it to be active. So this, as given, is not active, either one of these. And valacyclovir is the valine ester, which is a prodrug then. So how do these act? With acyclovir, the first phosphate is added by a viral enzyme, virally encoded enzyme, the thymidine kinase, or TK. And then the second and third phosphates are added by cellular kinases. The ACV triphosphate then is incorporated into the viral DNA by the virally encoded DNA polymerase. And this then terminates on DNA synthesis. Valacyclovir has to be hydrolyzed to remove the valine residues to produce acyclovir, which once it's converted then has all the same properties of regular acyclovir. What's helpful about valacyclovir is that it has much bioavailability over oral acyclovir. So we're going from 10 to 20% bioavailability to 60% with valacyclovir. Now, as far as treatment goes, we're using acyclovir and valacyclovir for HSV and VZV infections. And we have an oral and an IV formulation of acyclovir, and then valacyclovir, which is oral only, but as we know, has a much better bioavailability than regular oral acyclovir. And they can be used to suppress frequently recurrent HSV infections, which can be both genital and oral labial. We can use it in prophylaxis for herpes simplex and transplant recipients. And then for VZV, we can use it to treat adults with primary infection, which is chickenpox, and it's very serious in adults, or immunocompromised patients, or patients with shingles, which is the reactivation of VZV. So it turns out that VZV requires a higher dose for therapy than HSV. The drugs are excreted through by glomerular filtration and tubular secretion, so that you have to use dose modification if you have decreased renal function. And you can do this either by decreasing the dose or increasing the dosing interval. There are no significant drug interactions, which is good. We have minimal toxicity. The one adverse reaction that's probably the most common is nephrotoxicity, which results from crystallization of the drug and the renal tubules if you give an overdose, but this is pretty rare. And then we have some mild symptoms, which are not reported that often. A little more severe and of concern is hemolytic uremic syndrome and thrombotic thrombocytopenic purpura, which has been reported in AIDS and stem cell recipients. And these are patients when they're treated with high-dose valacyclovir for a prolonged time. Now, long-term therapy can pull out drug-resistant mutants, and the most common is a thymidine kinase deficient mutant, where you've got a frame shift or a nucleotide insertion or deletion in the coding sequence of the thymidine kinase. And this results in an enzyme which has reduced phosphorylation of its normal nucleosides, and in addition, reduced phosphorylation of antiviral agents. So you get resistance. We can also have a thymidine kinase altered enzyme. In this case, we have amino acid substitutions, so point mutations, that can result in, will not affect the phosphorylation of the normal nucleosides, but can reduce phosphorylation of antiviral agents. And then finally, we can have mutations in the DNA polymerase, which is encoded by these two viruses. And these are point mutations in functional regions, which alter the recognition of the drug by the DNA polymerase. There are no contraindications unless hypersensitivity has previously been documented. We don't have any documentation of teratogenicity, carcinogenicity, or mutagenicity. It is not approved for use during pregnancy, although we have no documentation that there have been birth defects in women who were accidentally treated in early stages of pregnancy. So another drug that's used for HSV and VZV is famciclovir. And actually the active form of this is penciclovir, which is does not have very good bioavailability. So pencyclovir is an acyclic nucleoside of guanine. So we got guanine here again. Famciclovir is a diacetyl 6-deoxy analog, which is a prodrug then. So you can see that we have 2 acetyl groups added to these 2 hydroxyls. This makes famciclovir easily absorbed in the gut. And once it gets into the system, then it's deacetylated in the blood, intestine, and liver. It requires further oxidation in the liver to become pencyclovir. So you can see that the base here is not quite the same as guanine, but once it's oxidized, it is. So we have guanine then and the 2 hydroxyl groups. And this is the active form. So pencyclovir, if you go through the stage of using the prodrug and then having it metabolized to pencyclovir, you'll have a much higher bioavailability. And pencyclovir then is anabolized the same as acyclovir. It requires a TK for monophosphorylation and then di and triphosphorylation by cellular enzymes. It's used in treatment and suppression of HSV 1 and 2 infections and herpes zoster or shingles with VZV. It doesn't have any activity against any of the other herpes viruses. It's only available as an oral formulation and it requires dose modification if the creatinine clearance is less than 60 mils per minute. And it turns out about half the patients who are over 50 years of age with zoster who are treated with it will require a dose modification. There are no clinically significant interactions. Some adverse reactions, which are relatively mild, headache, nausea, fatigue. You can get cross-resistance with acyclovir, which you would expect because they have a similar target. And again, the only contraindication is if there's been documented hypersensitivity. Now, ganciclovir is a drug of choice for CMV. And it's an acyclic nucleoside, again, of guanosine. We've got a recurring theme here. Valganciclovir is the valine ester, similar to what we saw with valacyclovir. Again, its bioavailability is much higher than the regular oral ganciclovir. It's hydrolyzed by esterases in the intestinal wall and the liver to yield ganciclovir, which is going to be our drug that's going to be metabolized. It is monophosphorylated intracellularly by the TK and HSV or VZV. Those of us who were working with CMV back in the late 80s were looking for a TK in CMV, couldn't find one. Turns out there isn't one. So there's the unusual case of viral protein kinase is fortuitously able to phosphorylate ganciclovir. So TK is a nucleic acid kinase, whereas UL97 is a protein kinase. We did not predict that. Ganciclovir triphosphate is then incorporated by the viral DNA polymerase into the DNA, and this results in termination of DNA synthesis, although it's not an absolute chain terminator, and that's because, or at least initially, and that's because you can phosphorylate one of these hydroxyl groups, but then you have the other one still available to add a nucleotide. Whereas if you compare this with acyclovir, it only has one hydroxyl group, which is once it's phosphorylated, it has no way of adding another nucleotide. So this ends up being a chain terminator after enough molecules are added. And our thought is that probably having multiple ganciclovir molecules in it kinks the DNA and makes it unable to add any more nucleotides simply because of the change in the conformation. It's used for treatment and suppression of severe CMV disease. And this is mainly in immunocompromised persons, HIV, AIDS, and transplant recipients. With HSV and VZV, they are sensitive to ganciclovir equally to acyclovir, but since acyclovir is much less toxic, that's the drug of choice. With CMV, it is not very sensitive to acyclovir, and ganciclovir is 10-fold more active than acyclovir for treatment. So the drug of choice is ganciclovir for CMV. It's also active against human herpes viruses 6, 7, and 8. The formulations we have are IV, and we also have oral ganciclovir, which we said had poor bioavailability, and then ganciclovir, which has an oral formulation only, but has increased bioavailability. And the dosage modifications are similar to what we saw with acyclovir. Now, as far as adverse reactions, this is a more toxic drug. It causes bone marrow suppression, leading to neutropenia and thrombocytopenia, and requires growth factors to support the white cell count. So it's also a potential teratogen, and it's contraindicated in pregnancy. You can see that this is a problem for bone marrow transplant recipients because you're trying to engraft a bone marrow, and here you have something that suppresses it and leads to neutropenia. It interacts with other bone marrow suppressive drugs such as azathioprine and vinblastine. It's associated with increased risk of seizure with imipenem cytostatin. It has an increased effect on toxicity of other HIV antivirals such as didanosine and zidovudine. And it's contraindicated if there has been documented hypersensitivity. Now, again, we usually treat for a long time, and that's a tendency to pull out drug resistance mutants. And the CMV UL97 kinase is a major target for that resistance. We also have mutations in the DNA polymerase, similar to what we saw with HSV. So HSV that's resistant to acyclovir is likely to be cross-resistant to ganciclovir. So you can't use ganciclovir as a secondary drug for drug-resistant HSV. So those are our nucleoside analogs. Foscarnet is an inorganic phosphate analog. That's what it looks like. And note it's a single phosphate group. It inhibits viral DNA polymerases at the pyrophosphate binding site. So it prevents cleavage of the pyrophosphate and therefore terminates the chain. It's not dependent on any phosphorylation for its activity. So this is the drug given, it's not further metabolized. So even though pyrophosphate's two phosphates, this single phosphate binds to that site and prevents cleavage of the pyrophosphate. It's active in vivo against CMV, HSV, and VZV, as well as acyclovir, ganciclovir resistant kinase and polymerase mutants. It's only given IV. Turns out it requires a lower dose for HSV versus VZV. It's excreted by the kidneys, so you have the dose modification as renal function decreases. And this happens fairly frequently, so you have to follow it over time. And there will be changing renal function resulting from nephrotoxicity, which is a major side effect. It interacts with other nephrotoxic drugs such as amphotericin B and aminoglycosides, and it's contraindicated if there's significant renal insufficiency. So the major adverse reaction is nephrotoxicity. Significant adverse reaction causes changes in serum electrolytes, calcium, phosphate, potassium, magnesium. It can cause nausea, vomiting, seizures, and anemia is another major side effect. You can have mucosal ulcerations actually from direct drug toxicity on the mucosal surfaces. Mutations that occur are in the DNA polymerase of HSV, VZV, and CMV. Cidofovir is a nucleoside monophosphate analog of cytidine, or a nucleotide analog. It's diphosphorylated by cellular kinase, so it bypasses the UL97 phosphorylation because it's already phosphorylated. And it turns out that cidofovir diphosphate is actually a triphosphate because you started out with one phosphate already and added the other two by cellular kinases. It's incorporated into the DNA by the viral DNA polymerase, and again, it's a DNA synthesis terminator. Now, we also have a free hydroxyl group so that it takes a little bit of time, a few molecules of cidofovir to be added before you do get chain termination. It's indicated for AIDS-related CMV retinitis, and actually that's the only FDA-approved indication, but it's used off-label for many other incidences. It can be used for foscarnet-resistant HSV, VZV, and CMV. And it's also active in vitro, at least, against pox viruses, adenoviruses, and polyomyviruses. And actually, it's been used off-label for treatment of these. It's given IV only. There was an oral formulation which was in clinical trials, but unfortunately, in the end, was not successful. Cidofovir needs to be administered with probenecid to decrease renal tubular secretion and toxicity. It has a long half-life, so this allows once weekly dosing initially and then dosing every other week for suppression of the viruses. You should not initiate therapy if the creatinine is greater than 1.5 mg per deciliter, or the creatinine clearance is less than 55 mils per minute, or greater than 2 plus proteinuria. Cidofovir causes increased nephrotoxicity with other nephrotoxic drugs, such as gentamicin, amphotericin B, foscarnet, pentamidine, vancomycin, NSAIDs. Because it has to be given with probenecid, it affects metabolism and excretion of other drugs that interact with probenecid, and here's the list. And there are other drugs, as listed here, which patients may be on but need to be held on the day of dosing. So nephrotoxicity is a major adverse reaction. Also leads to neutropenia, ocular hypotony, and uveitis. And probenecid has its own toxicity on top of that, which includes rash, fever, and nausea. We get mutations in the DNA polymerase that cause drug resistance, and these have been documented for CMV. And we have cross-resistance with ganciclovir polymerase mutants. So this is a diagram showing the metabolism of ganciclovir in CMV-infected cells and ways that resistance occurs. So if you start with ganciclovir, this has to be phosphorylated by the UL97 kinase. Should there be a mutation in the UL97 kinase such that it no longer recognizes ganciclovir, then you're going to get drug resistance. Once it's phosphorylated, then cellular kinases are going to add the next two phosphates. And then it's going to then come down here and interact with the CMV DNA polymerase and lead to inhibition of CMV replication. For cidofovir, this is a monophosphate analog. We have cellular kinases that are going to add second and third phosphates. Remember that the first one is already on the drug. It's going to interact with the CMV DNA polymerase and again lead to chain termination and termination of CMV replication. Now, should there be an alteration in a catalytic site or increased exonuclease activity associated with the DNA polymerase, such that the drug does not get incorporated, you're going to get ganciclovir resistance and cidofovir resistance. For foscarnet, it's a pyrophosphate analog. It's going to interact with the CMV DNA polymerase, leading to inhibition of CMV replication because it's going to prevent cleavage of the pyrophosphate portion of the nucleotide. If there's an alteration in the pyrophosphate binding site so that it does not bind to the DNA polymerase, then you're going to end up with foscarnet resistance. These are a few miscellaneous antiviral agents. Trifluorothymidine is the same as thymidine, except it has fluorines instead of hydrogens on a methyl group that's attached to it. It's a topical agent for herpes keratitis, which can lead to blindness. There are no reported drug interactions because it is a topical agent. We have imiquimod, which is used to treat human papillomavirus genital warts. It's again a topical agent. It causes an immune response activation, which leads to secretion of cytokines, mainly interferon alpha, IL-6, and TNF alpha. And it causes non-specific inflammation as a side effect, little dermatitis, headaches, flu-like symptoms, diarrhea, fungal infections, but basically these are minor. Trichloroacetic acid can also be used to treat HPV genital warts. It's a topical agent, causes chemical coagulation of proteins. And actually, those of us who've worked in the lab have used TCA to precipitate proteins. And finally, there's a newly approved CMV antiviral, letermovir. So it targets the terminase of CMV. When CMV replicates, it makes a series of copies of its genome that are all linked in a linear fashion. And the terminase then is able to recognize the genome length, cleave it off, and allow it to be packaged into virions, which are then infectious. So if you interfere with the terminase, you make a lot of CMV DNA, but it can't be cleaved and it can't be packaged, and you don't get an infectious virus as a result. So that's all of our DNA virus antivirals for the moment. We will have a second and third installments of hepatitis antivirals and HIV antivirals.